Dear colleagues, the case I will present to you today is a very rare condition and carries a high obstetric and fetal risk. In fact, it is a monochorionic triamniotic triplet pregnancy where we can see a single placental bed at the front and in the ultrasound scan. One fetus is positioned on the right, one in the center, and another laterally on the left. The patient is in the right week of gestation and reports a spontaneously conceived pregnancy. Monochorionic triamniotic triplet pregnancy is characterized by 3 genetically identical twins. In fact, it has a monozygotic origin, where fertilization results from the fusion of a single oocyte and a single spermatozoon. And the zygote specifically divides between the 4th and 8th day. After conception, this results in a single placental bed, but with separate amniotic sacs. It has an incidence of 1 in 100,000 pregnancies, making it a very rare condition. The incidence has increased in recent years due to the greater use of assisted reproduction techniques. In fact, only 20% are of spontaneous origin. Specifically, among triplet pregnancies, it represents only 1% of the total. It carries a high obstetric risk and complications related to monochorionicity, in fact. The placenta is single but shared among multiple fetuses and is characterized by the presence of vascular placental anastomoses. It is important for defining the prognosis of the pregnancy, especially in twin pregnancies, to assess chorionicity within the first trimester. This is evaluated by ultrasound through the insertion of the amniotic membrane at the placental bed, using the 2 signs known as the T sign and the lambda L sign. The T sign in the case of monochorionic pregnancies is a right angle, 90 degrees insertion of the amniotic membrane at the level of the placental bed. The lambda L insertion, on the other hand, is found in bichorionic pregnancies and is characterized by this typical acute angle into which part of the placental tissue inserts. Assess the number of placental masses, the thickness of the amniotic membrane, which is usually thin and sometimes not even easily visible. This is the case with monochorionic pregnancies, but much more often with bichorionic pregnancies. Then we evaluate the amnionicity, that is, the number of amniotic sacs. And finally, labeling, which is essentially a mapping of what they are, the twins, distinguishing them as twin 1, twin 2, twin A, twin B, in order to not only distinguish them, but also to allow us to orient ourselves, in the case, in any event, of subsequent ultrasound examinations. And labeling is performed by evaluating the relationship of the twin. With respect to the uterine cervix, in the specific case under examination, we observe, therefore, in a single anterior placental bed, the insertion of the amniotic membranes with this typical appearance of the T sign and the absence of the lambda sign. The membranes are thin, free, and floating. We can see 3 of them, distinct as the images progress, just as there are 3 fetuses. One is located inferiorly in a cephalic position on the mother's right, one on the left in breech position, and the other superiorly in a cephalic position. By observing the relationship of the first fetus, which is in a cephalic position at the bottom right, we see that it is indeed the first to come into contact with the uterine cervix, and in fact it is the first twin. One of the critical issues in multiple pregnancies is, precisely due to the high number of fetuses, the risk of prematurity. Actually, in 90% of cases, triplet pregnancies result in preterm birth, with over 80% delivering before 32 weeks and 15 to 25% before 28 weeks. Obstetric risks include preeclampsia, gestational diabetes, twin-to-twin transfusion syndrome, and postpartum hemorrhage, plus monochorionic risks from a shared placenta. In these triplets, this sharing is often unequal and imbalanced. Placental vascular anastomoses are often unbalanced between fetuses. Monochorionicity carries risks like a 15 to 20% incidence of twin-to-twin transfusion syndrome, characterized by a donor and a recipient. The donor often has a non-visible bladder and reduced amniotic fluid, while the recipient has polyhydramnios and an overdistended bladder. 11 to 20% of TAPS cases, whether sequential anemia or polycythemia, involve a condition of chronic and slow blood transfusion. Between donor and recipient, this is a spontaneous condition, but it's more often a post-laser complication for TTTS and SSTR. TRAP, a very rare condition, even more so in triplets, under 1% of cases, is the sequence of reversed arterial perfusion, where one fetus is the pump twin and the other, usually malformed and lacking cardiac activity called a cardiac, receives blood through reversed arterial flow via the anastomosis. Vascular, placental, and selective growth restriction affecting 25 to 35% of cases is common in monochorionic pregnancies, second only to preterm birth. Let's consider that in one of the fetuses, receiving a lower blood flow from the placental bed, therefore having access to a smaller portion of the placental bed since the division was indeed unequal. Among those who are twins in a multiple pregnancy, this fetus experienced a slowdown in fetal growth. Furthermore, congenital anomalies may also occur, particularly in the heart and brain, along with intrauterine death. In 5 to 10% of cases, hemodynamic imbalance causes hypoxic ischemic damage to the surviving fetuses. In 20 to 30%, it can result in the death of the survivors. This staging classification outlines complications of monochorionicity. TTTS ranges from stage 1 to 5, starting with amniotic fluid discrepancy, then no visualization of the donor bladder, followed by abnormal Doppler flow, fetal hydrops, and ultimately the loss of one or both fetuses. TAPS is diagnosed by evaluating the middle cerebral artery, specifically peak systolic velocity, which is increased above 1.5 multiples of the median in the anemic donor and below 1 mom for the polycythemic recipient. Peak systolic velocity worsens progressively through the stages. In TRAP sequence, one fetus is normal and the other is a cardiac. Selective growth restriction follows Delphi criteria. Diagnosis requires an estimated fetal weight below the 3rd percentile or 2 of 4 criteria, EFW or abdominal circumference below the 10th percentile, umbilical artery pulsatility index above the 95th percentile, or weight discrepancy of 25% or more. We distinguish types 1, 2, and 3. Type 1 has a favorable prognosis with persistent umbilical artery end diastolic flow. Type 2 is less favorable, with absent or reversed end diastolic flow. Type 3, with intermittent absent flow, has an unpredictable prognosis. Returning to the case at hand, we see the normal anatomy on ultrasound of the cephalic end. At this point, we observe a normally filled stomach, clearly visible on the left, just as the heart is also on the left with a normal situs, normal cardiac anatomy, and the long axis to the left. We have seen the 3 vessels, the normal 4 chambers, normal filling, a 3-vessel trachea view, the right section, and a V sign to the left of the trachea. Moving on to evaluate the biometric measurements, we see that the cephalic end presents with a biparietal diameter and head circumference within the normal range, and the abdomen also corresponds to the gestational age. Next, the femur length is measured, and it too is within normal limits. Growth perfectly matches the gestational weeks, indicating the absence of any actual selective growth restriction for the first fetus. Both the bladder and the stomach are visualized normally, and the amniotic fluid currently appears normal. Moving on to the second fetus, which is positioned on the mother's left side with the head at the top and therefore in a breech position, we observe the normal anatomy of the head. We have just seen the posterior cranial fossa, showing a normal cerebellum and cisterna magna. The measurements correspond to the weeks of amenorrhea, so the cranial biometry is normal, as is the cavum septi pellucidae. We then move on to the study of the cardiac anatomy. The 4 chambers are normal, the septum is intact, the right section is normal, and the left section is also within normal limits. With color Doppler, we see a vessel to the left of the trachea, and the 3-vessel view and trachea are normal. The stomach is filled regularly, the abdominal biometry is regular. We then see a normally full bladder. We measure the femur, which also corresponds to the pavodae, ameri, as well as the humerus. The measurements of the bones are also regular, long. Normal cord insertion, intact cord wall, 3 cord vessels, normal bladder. Moving on to the evaluation of the last foot, which is positioned above the other 2 twins below, we see a normal one, regular. Regarding the brain anatomy, the cranial biometry is regular and consistent with the gestational age. Similarly, the abdominal biometry is also normal. We can see that the stomach is properly filled and clearly visible. Furthermore, the biometry for both the femur and the humerus are regular, indicating that the bone development is also regular. Long bones regular. Bladder visualization is regular with normal filling, 2 umbilical arteries normal, cord insertion with an intact wall normal, cardiac anatomy is regular. Let's look at the left lung. 4 chambers, interventricular septum intact, right axis with color Doppler, 3 vessels, trachea, V6 to the left side of the trachea. And the biventricular filling is regular. Therefore, at this time, it is possible to rule out the presence of structural congenital anomalies, and is it also possible to rule out cases of TTTS? Because we have visualized normal amniotic fluid, 3 perfectly regular pockets, and the presence of stomach and bladder in all 3 fetuses. Therefore, this allows us to rule out some of the possible complications, including selective growth restriction related to monochorionicity, since the growth is perfectly regular for all 3 fetuses, and we will go on to observe this. Let's take a look, in fact. Here we see the biometric charts of the first fetus at the bottom right, then the one at the bottom left, and finally the fetus at the top. The growth perfectly matches the gestational age, and the growth discrepancy is only 2%. After ruling out cases of TTTS and selective growth restriction, we proceed to rule out cases of TAPS by evaluating the Doppler flow in the middle cerebral artery and the umbilical artery. For all 3 fetuses, these measurements are perfectly within the normal range. It has also been observed that in monochorionic pregnancies, there is a higher risk of developing selective growth restriction. It is actually correlated with a higher incidence of abnormal cord insertion. In fact, the insertion of the umbilical cord is a significant prognostic factor for stratifying the risk of growth restriction, and in particular, the selective type in the case of multiple pregnancies. It is essential to assess two aspects: the site of cord insertion and the distance between the cord insertions of the twins. As for the site, abnormal insertion such as velamentous insertion where the cord attaches to the amniotic membranes rather than the placental plate, or marginal insertion where the cord attaches at the edge of the placenta, can reduce blood flow to the fetus, resulting in an increased risk of selective growth restriction. A close distance, meaning insertions that are less than 4 centimeters apart from each other, is associated with a higher risk of developing hemodynamic imbalances with unbalanced arterial and venous flows. Therefore, there is a greater risk not only of selective growth restriction but also of TTTS. We therefore went to examine the cord insertions of our twin pair, where the first has a marginal insertion and the second has a paracentral type insertion. They are distant from each other, which makes us cautiously optimistic regarding the risk of developing TTTS and selective growth restriction. Management follows monochorionic protocols. First trimester checks determine the number of fetuses per placenta, and anomaly screenings are repeated. At the 16th week, a checkup is performed every 2 weeks. Biometry, proximetry, amniotic fluid, bladder implantation, and cord insertion checks in second trimester. At 22 weeks, the second trimester screening includes transvaginal ultrasound to evaluate cervical length and detect vasa previa. At 21 weeks, fetal echocardiography checks for heart anomalies common in monochorionic pregnancies. In the third trimester, biweekly ultrasounds monitor biometric measurements, Doppler studies, and amniotic fluid. It is essential to carry out prenatal neonatology counseling, and in the absence of complications, delivery is recommended at 32 weeks by C-section in a facility with a NICU. If complications arise, such as TTTS stage 2 or higher, selective growth restriction with abnormal Dopplers, or severe TTTS, we may offer fetoscopic laser coagulation of placental anastomoses from weeks 16 to 26. If a multiple pregnancy involves a malformed fetus, we may offer options under Law 194-CAR 1978, a selective feticide through cord clamping after multidisciplinary counseling. It is essential to provide counseling to the patient, explaining that in 25% of cases the entire pregnancy may be lost, and in 50% the abortion of another fetus may occur. Thank you very much for your attention.